I'm going to introduce our next speaker, Dr. DarrellTan from St. Michael's Hospital. Sorry. Can someone, do you mind setting up the PowerPoint while I introduce you? Dr. DarrellTan is an infectious disease physician, clinician scientist, and Canadian Institutes of Health Research new investigator whose research focuses on clinical trials in human immunodeficiency virus prevention and HIV or sexually transmitted infection co-infection. As director of University of Toronto Clinical Research Unit on HIV prevention and co-leader of the CIHR Canadian HIV Trials Network Biomedical Prevention Working Group, he is leading multiple efforts to optimize the implementation of HIV pre- and post-exposure prophylaxis in Canada. These include Canada's first demonstration project of daily oral TDF, FTC-based PrEP in Toronto MSM, the development of national clinical practice guidelines on PEP and PrEP use, exploration of the relationship between syndemic health problems and clinical outcomes of PEP and PrEP, studies of nurse-led PEP and PrEP, and evaluations of novel antiretroviral PEP regimens. Additional research interests are the interaction between HIV and common co-infections such as herpes simplex virus type 2 and syphilis, and the role of systemic inflammation in driving clinical outcomes in people living with HIV. He is also co-principal investigator on 2 CIHR-supported multi-center randomized control trials, including the trial of anti-herpes medication for attenuating HIV disease progression and the trial of enhanced syphilis screening in HIV-positive men. Here's Darrell.
Thanks so much, Michael. Thanks so much, everyone. Merci tout le monde. It'll be really hard to top that. No pun. Maybe it won't be, actually, given what we just learned, Damon. Okay, but to switch gears a little bit, I'm gonna present you, results from a clinical study that we did in Toronto a few years ago. My disclosures, I didn't put a slide, but my institution did receive support in the form of drug for this study from Gilead and for another study that's forthcoming. And similarly, my institution has received funds from ViiV for another investigator-driven study, and I'm also a site PI for some industry-sponsored clinical trials by GSK. So, we all know, as we've just been hearing over the last couple of days, that daily oral TDF/FTC can reduce the risk of acquiring HIV in gay men, gay, bisexual, and other men who have sex with men, or GBMSM, by virtually 100% if the adherence is high. That being said, in the earlier stages of kind of PrEP rollout, shortly after the first studies were published, my group had done a number of studies across Canada, looking at different stakeholder groups to kind of see what people were thinking about this before it was widespread. And a lot of the concerns arose about topics that we all could have predicted. So concerns that people weren't going to be able to adhere to their medication, that people were going to take excessive, whatever that means, sexual risk taking, and that there could be problems with toxicity and tolerability. And here are just some examples of some of those papers where we had looked at the opinions of frontline providers at AIDS service organizations, physicians, pharmacists across Canada. So as a result of that, we thought, all right, we've got to develop some data. The only way to address these concerns that people have is to show data. We wanted to do that with Canadian data as well. So from October 2014 to June of 2016, we conducted a study that we ended up calling PREPARATORY 5. It happens to be the first PrEP demonstration project in Canada among a bunch of Toronto GBMSM. It was one of a suite of studies that we called the preparatory studies. It's this clever acronym, we thought, for a bunch of studies that we did in Toronto, looking at kind of acceptability, readiness of PrEP before it had become a reality in collaboration with a number of academic and community partners. The objectives of the study are listed here. So the primary objective was simply to measure PrEP acceptability. Not that earth-shattering concept, but we thought it was worth doing in those early days before it was widespread, at both the community level, which we wanted to quantify using the referral rate to the study, and at the individual level, which we looked at using questionnaire data, which I'll show you today. We've presented the community level data before at the CAR conference. I'll talk a little bit about the individual level data today. And then the secondary outcomes were to look at things like adherence, a number of clinical outcomes like incident HIV infections, sexually transmitted infections. eGFR stands for estimated glomerular filtration rate, in other words, renal function. Bone mineral density is another outcome we've looked at. I'm not going to present that today, but we presented it earlier this year at the ID Week conference in San Diego, as well as adverse events. I'll show you some information today about sexual behavior, and then we also looked at the burden of syndemic health conditions in the screened cohort, and we presented some information on that previously at the CAR conference a couple of years ago. So this is what the study design looked like. It was a small study. It was an open-label one-year demonstration project, but it was small because it was really conceived of as a pilot, a prelude to a larger national demo project that we had hoped to conduct. Unfortunately, though, we had a lot of delays with study initiation related to contracts and REB approvals and things like that. So you can see at the bottom the timeline that you also heard Damon just outline really nicely from his perspective in the States at the bottom. So major landmarks are shown at the bottom of the slide. We had the idea of doing these studies in late 2012, applied for some grants and got those grants by early 2013, and it would have been great timing had we been able to launch right away, because then we would have had results to present to the world at the same time that other major findings were being presented in other contexts around the world, like the IPREX open label extension, PROUD and EPRGay coming out in 2015, etc. Unfortunately, right after we got our no objection letter issued in the middle of 2013, and we started the contracts process and REB process, it took an awfully long time because of unfortunate legal and just logistical paperwork problems, which were kind of out of our control as the investigators. As a result, by the time we opened to enrollment in late 2014, the field had really kind of moved on. And that's the way it is sometimes in research. As a result, though, we certainly still continued with the project, but we've really reconceived our idea of being a pilot as a pilot for implementation studies as opposed to a pilot for a national demonstration project because, of course, at this point, implementation is already rolling out. So these are the eligibility criteria for the study. Participants had to be a self-identified adult, gay, bi, or other man who had sex with man who had sex with men, needed to be HIV uninfected, needed to have an elevated risk score on that validated HERE MSM score that others have mentioned in the last couple of days, and have condomless anal sex in the last 6 months, and reasonable renal function. That's what that CRCL greater than or equal to 60 means. They also needed to not have HIV seroconversion signs or symptoms because we know that the testing is not completely perfect, and that's one area where we know there's a little bit of risk at the time of starting PrEP. They needed to not have used PEP or PrEP in the last 3 months, be on other kind of kidney-damaging drugs, be hepatitis B infected, or be participating in any other HIV prevention study. The intervention was open-label PrEP, as we know it. So it was Truvada, donated by Gilead, 1 tablet once daily, and the sample size was small. This was conceived of as a pilot, as I said, so only 50 participants, and that sample size was based on both feasibility concerns as well as being able to estimate the proportions that we wanted to measure with reasonable precision, as shown in the bullet point there. So the study schema is shown in the picture at the bottom. You can see that we had referrals from self-referrals. So we put up an ad on Grindr for just a week, actually, as well as Extra, both the print version when that still existed, as well as Extra online. We had a number of community-based organizations, that's what the CBO stands for, referring to the study in Toronto. And then people came in and were screened if they were interested in potentially participating. If they were eligible and provided consent, then they attended visits at baseline, months 1, 3, 6, 9, and 12. An extra visit was conducted as well if they had symptoms suggestive of HIV seroconversion, so we could test for acute HIV. That only happened once that someone came in for that reason. And at each visit, we did the things listed there. So a physician assessment, HIV point-of-care testing, as well as formal laboratory testing for HIV and other things, questionnaires, and drug dispensing. The outcomes are listed on this slide and the next one. So the individual level acceptability was simply measured with a very straightforward question. How would you rate your experience on PrEP? We asked that at every single visit, and it was on a 5-point Likert scale, and we just averaged the results of the available study visits for each participant, and I'll show you that in just a minute. And then we looked at adherence using 3 different measures. So we counted pills that people were bringing back to each visit to see how many they looked like they had taken. We also asked them using a 4-day recall instrument. And then most recently, Finally, we also looked at tenofovir diphosphate levels in dried blood spots using our collaborators' lab in Denver and Colorado. The clinical outcomes are listed here. So we measured HIV using a 4th-generation antigen antibody combo test, did STI screening using standard NAT testing in the urine, as well as rectal and throat swabs, syphilis serology, measured renal function using the estimated GFR using an equation called the Cockcroft-Gault equation, and then asked people to report any type of event that could be considered an adverse event. Finally, we looked at sexual behavior in questionnaires that asked people about the number of partners that they had, as well as the number of sex acts that they had with those partners. We stratified, or asked people to stratify those according to the status of the partner, HIV positive, negative, or unknown. I wish that we had asked about viral load status for the POS partners, but we didn't have that sophistication at the time, unfortunately. But all of this was over a 6-month look-back window. So here's a summary of the enrollment process. So we had self-referrals and provider referrals resulting in 86 screened participants. I won't comment on it in detail here, but we also kind of looked at the rate at which this happened as a measure of community acceptability of PrEP, and not surprisingly, it was very high. Out of those 86 screened participants, 52 qualified and were ultimately enrolled after providing informed consent. And here are the baseline characteristics of those individuals. You can see that it was mostly white. You can see that all participants identified as either gay or bisexual and had a pretty high level of education, a little bit perhaps more diversity in terms of income on the right. And I want to point out that although people were not, the median number of prescription medications that participants in the study took was 0, the median number of supplements that people took was 1, meaning that most people in this small study actually were used to taking something each day. Okay, but it was of their own volition, but that might have some implications in terms of the adherence that we observed. You'll also see that the previous history of STIs was very high in terms of bacterial STIs like gonorrhea, chlamydia, and syphilis. So 70% of the participants had had an STI in the past, and their baseline HERE MSM score was on the higher side, 29. If you're not familiar with that scale, it goes from 0 to 47, 47 being the highest possible risk, and the authors of the scale suggesting that if a guy has a score of 10 or greater, they should at least be considered for PrEP. So 30 was on the higher side. So here's the acceptability data. I don't think it's very surprising, but people were very satisfied with their experience on PrEP. 100% of participants rated their experience on PrEP as 4, meaning good or higher. The median score, when we calculated it across all of the visits, was 4.8. And the data completeness was pretty good. 81% of participants gave us 5 data points from which we could calculate that result. So that's not too surprising. Here's what the adherence looked like. We measured it in a number of different ways, as I said. So this first bit of data is the pill count data. I'll orient you to the picture. This is the data at months 0, so baseline. No one was taking it yet, of course, but then months 1, 3, 6, 9, and 12. And the box plot here just shows you the distribution of results for the participants. So overall, the adherence was very, very high by pill count, 97.3%. And if we kind of slice and dice the data up a little bit more to estimate the proportion of visits at which the dosing seemed to be 7 days per week, so every day of the week, 4 to 6 days per week, or 2 to 3 days per week, you can see that at the vast majority of participant visits, people seemed to be taking their doses 7 days a week. These categories are important because, of course, data from the external study, the IPREX open label extension, have given us estimates of just how effective PrEP can be if your adherence is in each of these categories. And I'll allude to that again in a minute. So the second way that we looked at adherence was by self-report. So just over the last 4 days, how many times did you take your pills? And again, it is pretty consistent with the pill count data. So 90% or so of visits, at 90% of visits, people appeared to have taken or reported that they had taken their doses for all four of the last 4 days. And you can see the numbers drop down just a tiny bit after that. But here's the results by dried blood spot testing. So the color coding tells you whether people were taking their doses less than 2, 2 to 3, 4 to 6, or 7 doses per week at months 1, 3, 6, 9, and 12. And it tells a very similar but a slightly different story compared to the last data I showed you. You can see that the vast majority of these pictures are blue, meaning 4 to 6 doses per week, or green, meaning every single day in the last week. There's a little bit of variability, though, at the first and last visit. So I think it's interesting for a couple of reasons. I think, based on some of the qualitative data that we've also collected out of this, this project, that part of the reason that this adherence looks like it's a little worse at the last visit is an artifact of the context in which we conducted this trial. So unfortunately, although we had attempted, as I mentioned yesterday, to negotiate ongoing access to the drug beyond the 12 months of the study, we were unsuccessful in obtaining that. And that meant that participants in this trial knew from the outset that at the end of the 12-month period, they were not going to have access to the study drug, to Truvada through the study any longer. So to be ethical, we discussed that with people up front. We tried to plan with them what contingencies might be available. We tried to support them as much as we could, but we suspect that some of the participants might have actually just been stockpiling a little bit of their drug towards the end of the study because they knew that they were going to run out, and that might explain this apparent drop-off over here. The other thing to point out is that at the first visit, I think part of the reason that this looks a little bit low is that we know that this is a drug that has a long, what we call accumulation half-life. That means it takes a long time for it to build up in cells even if you're taking it every day. And as a result, by the 1-month visit, levels might not have just accumulated in the cells yet, and as a result, it might have looked falsely like the adherence was a little lower than it actually might have been. So I've just shown you here at the bottom now what the numbers looked like on the last slide for the pill count estimates. And then when you look at the dried blood spot estimates, it looks like at only half of the visits was the adherence every single day per week. But again, if we exclude the month 1 visit, these numbers go up a little bit because of that accumulation issue. Okay, so it looks a little bit lower than the pill count data and the self-report data, so maybe some of it's a bit more objective, of course. It's much more objective, but there's these other reasons that it might have looked a little bit lower than it might actually have been. Okay, in terms of clinical outcomes, not unexpectedly, we saw 0 HIV seroconversions over the 48 or almost 49 person years of follow-up, which is great news, not entirely unexpected. And also, perhaps as expected, we saw a high burden of STIs. So roughly half of the participants experienced at least 1 STI over the course of the 12 months. The table breaks it down according to which particular pathogen. I've clumped non-specific urethritis along with chlamydia. We'll separate it out for the final analyses. We've also broken it down by site. So even though the absolute number of infections was low, when you calculate it in terms of a rate, the rates were very, very high. In fact, they're quite consistent with what's been reported in other large international PrEP studies, such as the PROUD study. We also saw a little bit of LGV, consistent with the known re-emergence of LGV in gay guys in this country. And then here's the renal finding. This is kind of interesting, I think, because we did observe a very modest decline in the renal function over the course of the study. We know that in health, renal function actually declines ever so slightly over time by roughly 0.1 maybe milliliters per minute per month. We observed a slightly faster rate of decline. So if you squint at this line, it is kind of sort of going down a tiny, tiny bit, almost statistically significant in this very small sample. And this is consistent with what has been reported elsewhere. So we know that this drug does have an impact on the kidneys. But how often is it significant enough to actually cause us to get alarmed? Very uncommonly. We only observed 1 elevation in creatinine that was grade 2 out of the 4 grades on the DAIDS scale, and it resolved spontaneously even without stopping the drug. Finally, I'll show you some of the information around sexual behavior. So we asked people to report on, as I said, partners and number of sex acts at every visit. But for various statistical reasons that I won't get into, it was not possible for us to conduct an individual level analysis where we report the change in each of these parameters over time. So instead, what I'm showing you here is just kind of a grouped analysis for the whole cohort, what people reported for each of these questions at baseline, that's the left-hand box plot, and then at month 12, that's the final box plot. So in terms of the total number of partners in the preceding 6 months, you saw basically no significant change overall, nor in the number of HIV-negative partners overall. nor in the number of status unknown partners, but we did see an increase in the number of positive partners, and that was highly statistically significant, even in this very, very small sample of just 50 participants. And then when we parsed it even further, according to specific types of condomless, insertive, and receptive sex acts with those pause partners, you can see that in both cases the number actually looks like it's gone up. That was not the case when we did this with for HIV negative partners or for status unknown partners. So there are lots of limitations around this data. It was a single center. It was a pretty modest sample size for the reasons I told you before. I would also submit that we were doing this, there's probably something that we've just nicknamed like a vanguard effect. These were early adopters. These were participants that were among the first to access PrEP at all in Canada, and therefore they may have been particularly motivated, particularly knowledgeable about PrEP, and whether the findings that we found were generalizable or are generalizable to what rollout might look like in the real world at this point in 2017, I think is uncertain. Finally, we looked at a 6-month recall period for the sexual behavior, and there's going to be problems with that. People may not be able to quantify that all that well because of the longer look-back period. But what can we conclude? I think one important point that we can make is that the adherence was really high. And as a result, we saw no HIV infections. None of this is surprising to us in 2017, but given the context in which we were conducting it, I think it was important to document. And I've plotted the adherence using our most robust measure, the dried blood spot estimates, onto this picture here. This is a picture that other presenters were alluding to earlier from the IPREX open label extension study, in which they estimated the level of PrEP efficacy you could expect to see when gay, bi, and other men of sex with men take their pills 7 days a week, 4 to 6 pills times per week, 2 or 3 times per week, or less than that. And you can see all of the green area correlates with an expected HIV risk reduction of virtually 100%. And the vast majority of our study visits landed in that area. Adherence can be excellent to this drug. Bacterial STIs, however, were frequent. That's not a surprise. We've been talking about that for 2 days, but it's comparable to what was found in other MSM PrEP studies. It was comparable, likely, to what participants were coming into the study with. We were able to prevent HIV infection in this very high-risk cohort. And then finally, yes, some sexual changes in sexual behavior occurred. I don't think that's surprising, and I think we have to own that and just think about how we're going to address it. I think the impact on HIV is not an issue. It's likely minimal, and people were probably increasing the number of HIV-positive partners and number of condomless sex acts with partners intentionally. That probably has a very good effect on things like cohesion within our communities, positive potential effects on HIV-related stigma. There are maybe going to be some unintended or unwanted effects on STI spread, and we got to own that, and we got to wrestle with that. It's going to be a big problem, and I think part of the reason for that is going to be from just what we observed in terms of the sexual behavior. We know that lots of bacterial STIs in gay guys, for example, syphilis, are really, really concentrated in guys who are HIV positive. So as more and more HIV negative guys on PrEP start to kind of just mix with this other population, it's going to be epidemiologically a setup for more syphilis transmission. So we've got some challenges ahead of us from that perspective, but I think we need to just address it with open eyes. So we have some future analyses that are still coming out of this project, some impact of the community-based adherence support intervention that we introduced into the study, and some other things. But to close, I want to acknowledge most of all the study participants who made this research possible, the rest of the team members listed here, and the various funders of the project. Thanks so much.